multidisciplinary workarounds. They're probably the single most important process for managing our hospitalized patients. If you can make rounding more efficient and as a result provide more effective patient care, you'd do it, wouldn't you?
Would you?
Well, we've developed a new way of thinking about the old challenge of multidisciplinary workarounds. The key elements are centered around the idea of playing on a team. Now, we'll be using the terminology of a football team, but you'll see that this could easily be adapted to fit your favorite team sport. Any successful football team depends on the strength of its playbook. Every member of the team needs to know what his or her specific role is and how those responsibilities mesh with the other members of the team.
Okay. Excellent. Perfect. Wait. You did okay? get started. I love how that does that. Might as well get started. So today's gonna be a little interesting. I'm not Fred Southwick. He was supposed to give the lecture today. He gave it last year. Quite an interesting guy. He did his undergraduate studies at Yale and then came to PNS. Graduated in '73. He specialized in infectious disease. He's a vice chair down at University of Florida, and of course, that's the home of the Gators. So so his undergraduate, he played football and lacrosse at Yale, and then he's now in Florida. So he's taken the athletic metaphor the distance, you might say. So we're going to hear from him today. I'm going to do the speaking for him, and we have a couple of short videos where you actually get to meet Fred. He's quite an interesting guy. He came last year and spoke both in the lecture and then as a dinner meeting, and he has a book. He's very passionate about the field. He's had his own personal crises between his wife and himself that has driven him. He loves medicine. He loves everything we do, but he wants to solve a lot of problems. So this is his presentation. It was pretty funny when we met him online last summer. We kept saying, well, maybe we'll just call it Lion Rounds, and it just doesn't work. Even though Columbia, won this past weekend, I guess first time in 18 league games, so it's a turnaround. These guys are 7-1, the Gators in football, and they're ranked number 11. So what we're trying to do is look at teamwork in healthcare. Why do we have problems with it? What are Gator rounds, and then why, using a sports metaphor, does it help you understand interdisciplinary team rounds? So basically, it's kind of interesting that a decade since some of the early studies came out of errors in medicine and things, I like to use the word a decade of Brownian motion. Lots of activity, lots of things going on, but not really satisfactory answers. Things that increase failures in healthcare, and he really focusing on the issue of teamwork and multiple members of teams, many specialists. Things are fragmented. We should be working together, but we have challenges doing that. And then we have novice physicians who really are learning how to run the system and are majorly at the center of decision making. When we had our panel, I thought it was rather interesting. Everyone spoke about their love for the patient, their love for the field. But then, as Dr. Sharon probed the speaker, especially when it became, when Jesse Yang spoke and nursing spoke, and you saw some of the challenges back and forth and some of the feelings about each team and who was at fault and not. So there's definitely room for improvement. Now, a lot of this for Dr. Southwick came out of an experience he went to, I guess he was doing his MBA at Harvard just a few years ago, and they were taking a course, and it was on teamwork, and the students in the course had to break up into small groups and then go around Boston and find places where teamwork was being put to use in different businesses. And you can see here that a fifth of the class chose medical teams. There were 3 in the ICU and 1 on the med floor, and he worked with a team. And there's a paper you can see. We gave you the paper on Gator rounds, but this is actually, I think, a much more interesting paper than the results of his work was actually what led him to come up with the idea. And I'm just going to cover a little bit of what he found. The working groups were not working teams. Obviously, there was a hierarchy in the teams. There was a lot of one-on-one conversations, but people weren't really talking as a group. The case manager was often not there, and then the nurses were only there half the time, rarely spoke, and the pharmacist, though being there, never spoke. Now remember, this is his experience, in this course that they did. And other things they found, and the setup we gave you for the last exercise, where there was no formal process to launch the team, we did that on purpose because we wanted to recapitulate what actually happens, and that's what he found. So people in institutions decide there'll be interdisciplinary rounds, but there's really no formal process, no definition of goals. How do you measure it? How do you make decisions? and no protocols for communicating. This is what they found, and this is what we did to you last week, the last two exercises, and why today is different, where we're giving you a little bit more structure. What else did they find? An often problem where team members change. They're switching on weekends, and the time per patient varied greatly. Here's a case where one patient took 45 minutes, which left probably very little time for anyone else. They met in hallways, difficult to converse, and the business student's overall impression is quoted from the paper, "I hope I never have to be hospitalized." So this was really, not a good experience, and they wrote it up. They wrote the paper, and I guess it inspired Dr. Southwick to take everything he knew from his, long career, both from athletics and healthcare, to come up with a better system. And, why is it poor? Obviously, individual agendas. We do our job. We get measured, based on from our bosses, so we want to do it. We're all a bunch of experts. There's a thread in a lot of this of communication that's not the most respectful. And then you even heard when Jesse spoke a couple of weeks ago, that sort of distrust, when people say things about each other's group. He used some choice language, but he was speaking from the heart. So I want to show you a video and we'll get that Fred put together, and then there's a short video of an actual recording. So let's...
Multidisciplinary work rounds. They're probably the single most important process for managing our hospitalized patients. If you can make rounding more efficient and as a result provide more effective patient care, you'd do it, wouldn't you? Well, we've developed a new way of thinking about the old challenge of multidisciplinary work rounds. The key elements are centered around the idea of playing on a team. Now, we'll be using the terminology of a football team, but you'll see that this could easily be adapted to fit your favorite team sport. Any successful football team depends on the strength of its playbook. Every member of the team needs to know what his or her specific role is and how those responsibilities mesh with the other members of the team. Now, the patient can be thought of as the team learner. The patient's role is to ask questions, make suggestions about care, and actively learn about his or her disease. The senior physician attending is the coach. The attendant cares for the patient through the team members by asking guiding questions and encouraging the bedside nurses to actively participate in rounds. Now, out on the field, you've got the quarterback. During rounds, you've got your senior team resident. It's their responsibility to distribute the workload, supervise the interns, and generate the game plan for the day. The running backs are the interns and sub-interns who carry the ball. In this case, they directly care for patients by writing the orders. Of course, a team has little hope of reaching its goals without a strong offensive line, and these are the nurses who operate at maximum potential when they are involved in creating and executing the management plan. And always observing from the sidelines, you've got your assistant coaches. One assistant coach is the case manager who works with the team to create an effective discharge plan and helps head off impediments to care. Another assistant coach is the pharmacist. She helps the team in ordering medications, monitoring potential side effects, and teaching the patient about his medications. Of course, any team's success centers around the quality of the relationships between team members. On the field, that means knowing who's doing the passing and who's doing the receiving. In healthcare, you can think of this as a customer-supplier relationship, and it's not always as obvious as it may be on the field. Take the nurse-physician relationship. I think sometimes we doctors view nurses' role simply as being there to gratify our egos. In reality, it's the physician's responsibility to supply succinct orders and to make sure the nurse understands those orders. When this is the case, the nurse acts as a second line of defense against errors. For instance, if the wrong medication comes through the pharmacy, ideally the nurse can recognize that error and contact the pharmacy. Another important relationship is between the patient and the physician. Now, in our model, the patient is the owner of the team. Just as the team owner thrives on updates from the coaching staff, so does the patient. One of the most valuable exercises for a sports team is viewing game films, thinking objectively about what's working and which tactics need to be reevaluated. As frontline caregivers, we need to continually ask how patient care can be improved. A key question is this of value to my patient? If the answer is no, eliminate it. Let's take a look at a sample work round that follows our model of teamwork. Mr. Jones, good morning.
Morning.
How are you? Do you remember me? I'm Dr. Sopnick, and this is Dr. Holland, Dr. Baranas, and Dr. Doody. And this is the case manager, Michelle Lewis, and the pharmacist, Annie Snyder, and you know your nurse, Vicki. We wanted to present at the bedside and discuss your case. Is that okay?
Sure, I'll be fine.
Great.
All right, so as you know, Mr. Jones is our 59-year-old protein chemist who has chronic obstructive lung disease and who was admitted to the hospital for pneumonia. Subjectively, he has felt better over the last 24 hours. His sputum production has decreased, and now he only has scant white sputum production. Objectively, his temperature is 37.2, pulse is 70, respiratory rate of 16, blood pressure 130/80. On his physical exam today, his lung examination only reveals scattered RALs in the left lower lung field, and his E to A changes have now resolved. His white blood cell count has decreased from 14,000 with 90% PMNs to 9,000 with 70% PMNs. His chest x-ray 2 days ago demonstrated a stable left lower lobe infiltrate, and his sputum gram stain revealed gram-positive lancet-shaped diplococci. However, his culture only grew normal throat flora. His urine antigen, though, was positive for strep pneumonia. So for my assessment, Mr. Jones's pneumococcal pneumonia is steadily improving. And my plan, we can discontinue his IV ceftriaxone and continue him on his oral azithromycin alone. And in terms of disposition, if he continues to improve, I think that he could be discharged to home tomorrow.
Great. Mr. Jones, can I take a quick listen to you here? I'm going to listen to your heart first. Okay, can you sit forward for me? Take big breaths through your mouth. Okay, say E.
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 Right. So I agree.
Why don't we also give him an incentive spirometer, help increase his breathing capacity. Vicki, do you have any concerns for us today?
No, he's been ambulating in the hall without significant shortness of breath. He's eating all his meals. I think a discharge in the morning would be okay.
Is he going to need home oxygen? I noticed his SATs have been a little bit low.
He does have chronic hypoxia with exertion because of his COPD, so he will need home oxygen.
Okay. I can get that set up at home.
Great, good. So, Mr. Jones, do you have any questions at this point?
Everything seems okay. The azithromycin, when I take it, makes me a little bit nauseous. Is there anything else I could get?
So we could actually give amoxicillin, which would effectively treat the pneumococcus.
That should work.
Good.
I would recommend amoxicillin 875 milligrams twice a day for 5 more days. And based on his response to the ceftriaxone and his estimated renal function.
So ordering amoxicillin 875 milligrams PO twice per day for 5 days?
His insurance covers that.
Great. So, Mr. Jones, our plan is switch you to oral amoxicillin today and discharge you tomorrow for another 4 days of antibiotics after that. Now, just to be sure you understand our plan, could you repeat back the plan for you?
I'm going to be on amoxicillin for 5 days, and then I'll probably go home tomorrow, and I'll have oxygen at home.
Exactly. Really good to see you today, and keep up the great work on healing. Now, of course, you're not going to film your daily rounds, but you can improve your performance by assigning an external coach to watch the team at least weekly to assure the team is faithfully following the rounding system. Now, in addition to these 3 principles, team members must be proficient in the fundamentals. That is, the basic skill set unique to whatever activity you are doing. For healthcare, the first key fundamental is learning how to communicate succinctly and accurately. Use the SOAP technique, followed by a brief discussion of the disposition. The SOAP disposition presentation should take only 1 to 3 minutes because the presenter only needs to include key details pertinent to the active problem. Keep in mind that the attending has read the electronic record prior to workarounds. The second key fundamental is utilizing the huddle formation. The team actually forms a circle around the bed, and this huddle emphasizes the importance of all the team members and helps downplay traditional hierarchies. In this way, the huddle creates a zone of safety where everyone feels comfortable sharing their ideas on how to improve the management of the patient. The huddle also creates a shared mental model because everyone hears the same information at the same time, including the patient. So what happens when the rounding program is fully implemented by the team? Our pilot study reveals that both the efficiency and the quality of patient care improves. Patients cared for by the experimental teams had a relative length of stay that was nearly 20% shorter than the control team, and a 30% reduction in 30-day readmission rate from 9% in the control group to nearly 6% in the experimental group. In addition to improving care, we saw a trend toward improved patient satisfaction. And what about the other team members? Nurses felt more respected by physicians and felt that the physicians provided better care to their patients. Residents and attendings agreed that rounds were more efficient, and all the experimental teams achieved an average work round time of under 2 hours. Finally, medical students rated teaching and overall satisfaction with work rounds very highly, while students in the control group rated teaching as being mediocre. Finally, when a team gels, everyone feels a new sense of joy at work. As one intern noted, before the rounding system was implemented, I dreaded coming to work each morning. Now I can't wait to join my team to care for my patients. We hope you will enjoy implementing this team approach to care. Caregivers and patients win. We hope you will review the details of our approach at our website.
So that's obviously that was acted, right? So there's an interesting follow-up video, which is actually a film of a hallway rounds that I think...
Admitted for hypovolemia. She also has a history of squamous cell carcinoma of the head and neck and with epilepsy. This morning on exam, she was complaining of continued sharp pains in the bottom of her feet, which prevented her from sleeping last night. But otherwise, she's been doing well. She did sit up in a chair yesterday for several hours, and she enjoyed that. Her vitals were all stable. Her blood pressure is 121 to 139 over 70 to 92. Her physical exam remains unchanged. Her labs were, her BNP was normal, her CBC, her H&H are both low at 8.7 and 27, but she does have a baseline anemia under that, and then her platelets were 201 this morning. So as far as for her hypertension has resolved. For her depression, we had started her on citalopram. We're going to go ahead and increase that to 20 milligrams once a day today. For peripheral neuropathy, she's on the Neurontin, 200 milligrams TID. We're also going to give her a dose of amitriptyline, 10 milligrams at night to see if that helps her sleeping. PT and OT are working with her for deconditioning. And as far as disposition, she's going to go to a subacute rehab place so that she can get intensive physical therapy for deconditioning.
Did she come from a rehab?
Yes, she did.
And she's the one that doesn't like the one where she
Right.
is.
So she'd like to switch if possible.
Much easier if they go to the SNF and then they can just do a transfer from there, because we're never sure how many Medicare days they have left. There's all sorts of things involved, and I tried that once and it wasn't a good idea. So mostly we send them back to where they are, and then they can transfer from there.
They had mentioned that over the weekend. I think I saw the lift team getting her up in a chair earlier, right?
She was. She was up
meals.
for breakfast. She's getting up 3 times a day with her meals.
Okay.
Does she still have a problem with her stools, though? She had 2 loose stools last night, so I held out the laxatives this morning. She hasn't gone.
Over the weekend, it was a lot where I thought it was C. diff because it smells. It was negative.
Yeah, she's on Senna and Colbis, so it's
Okay, we
just
can take
kind of
her out
running.
to Senna then.
It's just running through her. So
Okay.
I held them out this morning.
Okay.
So in that one, you can see the the effectiveness of their conversation. So you split up last week to read the sets of papers. So one group's actually going to review the paper that it refers to with the results from the study. So, obviously the goals are timely, efficient, error-free, patient-centered. There's very few patients that, who want to stay in the hospital. There are no hospitals that want to keep patients in the hospital. Anything that keeps a patient in the hospital more time than needed is a problem. And, efficient rounds are critical. We've been doing a lot of work at NYP and various student groups over the years between interdisciplinary rounds and teaching rounds, and they really are a challenge. There's definitely room for improvement. And I think what you're going to learn in today's exercise, and if you're in the other group, you'll do it next week, is a methodology to be more effective. One thing I want you to be sure of and recognize that when you do go into clinical settings, you're probably not going to see rounds as idealized working like that are shown here or in our exercises. There are places where it actually works and other places where it doesn't. So as a student, your task is to study what works, what doesn't work, and try and understand what are the obstacles. Not that you're going to be able to make any changes now, but in the future, when you're leading a team and you're speaking up, you'll be able to make a difference. So obviously, having nursing involvement and teaching opportunities. You saw how the huddle was a great format. You saw how that in that live situation, how even though the intern was telling the story, the attending was there was that really neat conversation that was going on about the skilled nursing facility and the advice, about if you discharge in a certain way. And then there was that conversation about the bowel activity of the patient over the weekend, and that quick communication that went on was actually really, really important. And had it been hierarchical or people talking to the side or whatever, that wouldn't have gone on. So very, very critical. It's really important that everyone feels that they're respected in the communication, so they can speak up and say something, and not fear that they're not the person with all the expertise. This is the paper that he referred to. So you have that as assignment. Lots of good information in there. It was the follow-up to that paper where he went to the business school course that inspired all of this. The conclusions. Teamwork is poor in healthcare in a lot of places. You could learn from championship athletic teams. Having a protocol, having a list of things that you have to accomplish, and you'll see in your work material where each person has what they care about. Each person has a role, and then sitting back and looking at how the rounds works in the sense like a game film to get feedback, and then practicing it, being skilled in the fundamentals, and then the team will then harness the creativity of the individuals. One of the things that a lot of you probably have competed in sports, often the winning team is not the team with the star athletes. It's the team that comes together and gels. I know that statement up there that the resident who didn't want to come to work anymore and now can't wait to get up in the morning to go to work, that sounds a bit contrived, but that actually can happen when you're on a good team. Okay, so this is an interesting quote from 1925. The secret of the care of the patient is caring for the patient. And in 1925, it took a caring physician, but today it takes a caring team. An individual is not going to be able to care for a patient. It's the team that has to care for the patient. So let's, I guess we get out a little early today. Get over to your small groups and practice your rounds. The other half are going to go and hear what's going on at NYP in process improvement, in quality improvement, and then next week we'll swap. Any questions? And now when you go out there, you don't know what role you're going to play. So hopefully you will get it all mixed up. And you'll get enough instructions early on, and you did it the last time. But now, having read the papers and a little more notion of the structure, I think it'll go a lot smoother. So enjoy.
12 minutes to talk,
Thank
3
God.
3 minutes for questions, so
Okay,
14
so
total.
that's too long. Totally
None of them look blurry up there. They're all slightly different sizes, which is gonna bother me.
What?
Like, they're slightly different sizes.
I know, but they just, I couldn't.
No, we can just change that, like, the sizing. Oh, that's good though.
It's also backwards, but, you know, she'll just have to actually prepare the information if she wants to see it. Well, she wants to prepare it,
Great. She wants, so that way she can give us feedback on it. And like how we present in this space.
Look, it's been 22 minutes since we started.
Good. I can write down notes like as we're like.
The entire video is going to be recorded backwards.
Is it recording? Hello. Back up. What's up? Right here?
How's it going?
Okay. That sounds good.
Cool beans, bruh.
Yeah.
Yeah.
Yes, we
Yes.
do. Well, and you can read off the
Hello.
slides.
Yeah.
Hi, Becca. We have one audience member now. Woo!
I got the buttons to work.
Oh, excellent.
So, yeah, so if we think of things as we're presenting, we can just like scribble them down. So we
I
can
don't
time
know
it.
how.
I just realized that my notes are on the computer.
Oh.
Oh. Well, Becca's here. She can record it and.
I don't know how to make this. Yes, I do. Got you. Hey, Becca.
You know what I can do? I can, because I only need this one thing right here, really, and the rest are reading off. I can just take this on my phone. Use my phone. Yeah, no, we're good. I got it. I'm gonna press the button and then run over and then.
Okay, or we could have one of them press the button.
Yeah,
Can you press the button?
Are you gonna time it or should I?
you can do it. Should I read the title? I guess. I'll just read it.
Or you can do the route. And here is Rochelle Patty Terry
No.
doing the validity of FMR.
I'm just going to read. We are doing the validity of a functional memory to identify impaired range of motion of the hip. Jamie V is watching from afar.
We're recording
to
to
send to her. Because she hasn't
can't make it.
seen it.
Because we haven't done it yet.
Oh, is it recording? Has it started? I just literally was like, Stop. So I was like, oh.
Shaky shake.
I think it's going now. So we are doing the validity of the functional movement screen to identify impaired range of motion of the hip. So a little bit of background. So we looked at the functional movement screen, also more commonly referred to as the FMS, and you'll see that throughout the presentation. So the FMS is a screening tool used to identify physical imbalances and weaknesses in individuals. The FMS is made up of 7 individual tests that require strength, flexibility, balance, and neuromuscular control. Each of these 7 tests are scored from 0 to 3, with 3 indicating a normal test and a 2 or below indicating abnormal. These 7 tests are then added up to make one total score with a maximum value of 21. So these are the 7 individual components of the FMS. And in parentheses, you'll see the abbreviations for them, and we're going to use these throughout the presentation. So if you don't remember, we can always refer back. No, we can't. So the FMS has been looked at in terms of reliability and validity. For reliability, the FMS is shown to have acceptable inter- and intra-rater reliability. Research demonstrates varying ICC values from 0.76 to 0.96 for the total FMS. And research has also looked into raters with varying levels of experience. So not everyone is an advanced FMS user. In terms of validity, the FMS has been validated in its ability to identify individuals with an increased risk of injury. These individuals are those who end the test with a total score of 14 or below. And this has been validated in varying populations, including adolescent collegiate athletes, firefighters, and military personnel. So what's the purpose? There are 2 purposes for our research that we wanted to investigate. The first one was to determine if there was a relationship between the FMS and traditional goniometric measurements of hip ranges of motion. And the second one was to determine if the FMS was a valid screen to identify impaired ranges of motion at the hip.
So we got IRB approval through Columbia University to place flyers at the Columbia University Medical Center and at the Morningside Heights Columbia University campus. We got informed consent from all of our subjects. They had to be between the ages of 18 and 35 years and must be English speaking. They were excluded if they had orthopedic surgery within the past year, if they had injuries spelled wrong, if they had an injury to their arms, legs, or back within the within the last 6 months, and had 2 or more days missed from work due to the injury. They also could not be on any medications that altered their sensation or alertness. We did an a priori analysis that deemed 15 subjects were required for this study, and we were able to obtain 15 subjects. So each of the subjects went through a series of stations. The order of the stations was randomized between each subject. The values were found for hip goniometric range of motion, active and passive, for flexion, extension, internal rotation, and external rotation. We also did handheld dynamometry to measure their strength at the hip for flexion, extension, and abduction. They also went through the full FMS under the guidance and scoring of a FMS certified clinician. And we did inter-rater reliability prior to data collection, and that was found to be good. First, looking at our data, we did Spearman correlation of the various hip range of motions, active and passive, to the various FMS components. Here is the highlights of those that were deemed high or very high. We had 5 that were deemed very high. Flexion, passive range of motion to the inline lunge right. Extension, active range of motion to shoulder mobility left. External range of motion, or external rotation, passive range of motion was found for active straight leg raise right and left, and then external active range of motion was the only one that had a very high correlation with the total FMS. So this does indicate that there is some relationship between the FMS and its components to traditional physical therapy goniometric measurements. I forgot what I was going to say. Okay, all right.
So we're going to get into the next bout of results. I wanted to make these values more specific to our research so you know what's going on. So for sensitivity, that indicates the proportion of abnormal scores correctly identified as impaired. Specificity is proportion of normal scores identified as not impaired. The positive predictive value is the probability that subjects with an abnormal score truly do have this range of motion impairment. And the negative predictive value is the probability that subjects with a normal score truly do not have this hip range of motion impairment. So we're going to start with hip external rotation here. It has the highest and best results of all of them. You can see all this red on here. Very high is highlighted in a darker red, and high is highlighted in a lighter red. This is our internal rotation, our extension, and our flexion. If you want a closer look at those one day, let us know. So our second question asked if the FMS was a valid screening tool to identify impaired range of motion at the hip. And the answer is that it's some of it. We have 100% sensitivity for both deep squat and rotatory stability, indicating that if you have a normal deep squat or a normal rotatory stability, you can be pretty sure that there's no hip range of motion impairment in external and internal rotation or in flexion or in extension. Then we go on to specificity, which was very high for the total, indicating that if we had an abnormal total, there's a high probability that hip external rotation or hip extension was impaired. We had a high positive predictive value for all of the FMS components, indicating that if any one of those 7 components was abnormal, there's a high probability that you had a hip external rotation impairment. And then we had a low negative predictive value for the total, indicating that if you are given a normal total, one that's over 14, that does not necessarily indicate that you don't have a hip impairment.
So some of the limitations of our study. So first, we had a sample of convenience. So we were only able to recruit out to the medical and the Morningside campuses here at Columbia, and none of our subjects came from anywhere else. Small sample size, as previously mentioned, while it did fit the minimum number required from the priority power analysis, 15 is still a relatively small sample size. Given our ability to recruit to these people, our population ended up all being in the young adult population, so we want to be able to look into a more diverse population. Another limitation is that our impaired range of motion indicated both hyper and hypomobile people. So when we gathered the data on range of motion, we were classifying it into abnormal or normal, and based on norms, people who had increased ranges of motion but were outside the norms were technically classified as abnormal. So that could have affected our statistics. And lastly, we had no subjects that got a normal test score for the deep squat or rotary stability test. So that doesn't allow us to truly be able to tell if it would pick up on abnormal ranges of motion. So in conclusion, there are 3 main conclusions we can make from this. The first 2 are with using the FMS within your clinic. So for one, if you want to administer the FMS in your clinic and your patient receives an abnormal score on any of the 7 tests, then that would warrant having a closer look at hip external rotation range of motion. Another conclusion we can make is that in the clinic, if you wanted something you could do quickly, we found that you could perform the deep squat test or the rotary stability component, and those could be used to identify general hip range of motion impairments. And the last point here is referring to a case where your patient may come into the clinic with a total FMS score from a previously administered test, and that if your patient's score was abnormal, so equal to 14 or less, then we could, they would most likely have impairments in hip extension or hip external rotation. So for future study, just a few things going off our limitations. We would want a larger and more diverse population. We could also look and compare the FMS to other types of movement assessments that we could use in the clinic. Another thing was we had originally wanted to include statistics looking into hip strength, But given the lack of standardized values, normal values, using the handheld dynamometer, we were unable to do so.